Hi, everyone. Welcome to another episode of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and it's wonderful being back with you. As I've said before, it's fun to educate others on the way we think, the way we approach patients, but also I learn when I'm interviewing and presenting cases to others. So I'm excited to have a wonderful guest, a good colleague of mine today who will be teaching us something about an interest patient. So sit back and enjoy this episode. So, welcome to another Lessons from the Lab episode. It's a pleasure to introduce the guest for this episode, Dr. Mike Skolka. Dr. Skolka is an assistant professor of neurology at Mayo Clinic in Jacksonville, Florida. Funny that you should be here at Mayo Clinic. He is a rising star in the EMG world. I shouldn't say rising, he's already there. If any of you have been to the AANEM meeting, he's won a number of research awards over the last couple of years. He's been the Young Leadership Liaison representative. And it's really good to have you here, Mike. Thanks for joining.
Oh, thank you so much for having me, and thank you for that kind introduction. I'm honored to be here. Big fan of the lessons, and I always learn so much from them. So I'm excited to participate with you.
Well, good. Well, I learn, we learn from each other every day. In fact, you have a little bit of a claim to fame. My last guest in the last episode was the guest that lived furthest in distance from me. Was she lived in Malaysia. You're the
Oh,
guest that's the closest in distance to me. We're basically right around the corner from each
that's true.
other.
That's true. It's
So
funny.
so I know we see each other every day. I'm going to ask you, I'm going to put you on the spot and ask you a leading question and say, what do you find the most rewarding thing about working in EMG at Mayo Clinic in Jacksonville, Florida?
Well, obviously, working with you is the best. Is the best. No, in all seriousness, I'll expand it to say I think we have a strong team here. We come into the lab, and the physicians who are in the lab, but also the technologists who are here. I think we're just a good group and work well together, and it's just fun. I mean, it's work, but it's also it's enjoyable, and I think that's important.
Yeah, and I'll kind of expand the question. I didn't really want to make it specific to our lab, but I agree with you. I think I always say our lab is the most fun place at Mayo Clinic, that
Yeah.
we have joy, we work together and really enjoy, and it shows, not just us as the physicians, but the techs as well. And I think patients really understand not only the expertise, but the enjoyment we have in doing what we do to try to help them. But I guess I'll also expand the question just to EMG in general. I mean, you're relative you're much younger than me. You've been on staff for over a year here, so but I'm curious what appeals to you or has always appealed to you about what we do.
Yeah, good question. So for me, I like the puzzle. I think EMG and the patients we see are puzzles in trying to piece together, their history, their exam, their electrodiagnostic findings, and they all work together as data to, determine an outcome. And as they can. It's not always clear cut, and so it can be fun, and I think that makes it fun trying to thinking through what are the possibilities, what could we do test for to try to help them out.
Yeah. No, I agree completely. I think it's a different way of thinking than when we're in the clinic. There's some similarities, but then there's also the decision making in terms of what tests do we need to do or perform to try to come to that diagnosis. And I think one of the things I enjoy working with you is the mindset that we have is very similar, not only in what we do in our day-to-day practice, but trying to expand what we know. And we talk all the time about sort of should we be doing this in a different way, or and I think that makes it fun and advances the science as well.
For sure. No, we have just for the listeners, we have a nice whiteboard in our lab where we start to just write down ideas, and we're about to need a second whiteboard. I mean, we've kind of reached the bottom of it, but we try to jot these things down as we're coming up with different research ideas or things to look into. But
And not only do we jot them down, but we'll occasionally have a pizza party at the end of the day with several of us, and we'll go into a room and shock each other and sort of try to figure things out. And
we
I'm
did.
sure the listeners are going, "Boy, these guys are geeks," but yeah, but that's how you advance. If you think in a different way, right? And we don't just say whatever
Yes.
we've done is always the right way to do things. We need to think differently or try to expand. I think that's how we advance what we do.
Yeah, totally agree.
Yeah. So, well, I'd like to learn a little bit from you, and I'm gonna, as you know, in listening to these, what I like to do is present a case. I know we work together, but this is not a case we've talked about. Usually, we talk about many of the challenging cases, and this is a case that I'm curious as to how you would approach this to see if we would do things exactly the same way or if there'd be some variety in how we approach this patient. So you up for it?
Sounds good. I'm ready.
Okay. So I'm gonna just share there's a few slides here. I'm gonna share this, and it's a pretty straightforward case. I'll read it for the people who are listening and not watching this. So basically, the patient was referred to the EMG lab. It was an 80-year-old woman who was referred for an evaluation of right shoulder pain and dysfunction. And her history was a bit complicated. I'm going to make it pretty simple, though. She had a history of breast and thyroid cancer. Her breast cancer was years ago. It was metastatic. She had mediastinal nodes and retroperitoneal nodes and some bone metastases. And she was treated with hormonal treatment and some chemotherapy, never had radiation. And then and she was doing okay. And in 2017, she was found to have enlarged nodes in her neck, was found to have metastatic papillary thyroid cancer, and underwent a right radical neck dissection to remove the cancer. And so the surgery was on her right neck. At some point after that neck surgery, I don't know the exact timing from looking at the history, but at some point soon after, she noted quite a bit of pain in her right shoulder and dysfunction of her shoulder. And from what I could tell, she had just limited range of motion of the shoulder, had a hard time kind of moving her arm around. So she was sent here to Mayo Clinic. She saw someone in our orthopedic department. This was a couple years ago. And the examination that was listed was fairly simple. What was noted in the exam was there was limited range of motion in the shoulder. Not really sure exactly what that was. There was some winging of the scapula laterally, and they noted, and you can see in quotes, 5 of 5 shoulder shrug. And that was pretty much it from what I recall in the notes. And she didn't see neurology, so I don't have a good neurologic exam. But I don't think there was any other noted abnormalities in the arm, except for
Okay.
one sort of abnormal in the shoulder.
Okay.
So that was basically it. She didn't really have any other problem anywhere else. Nothing in the left shoulder. It was all the right side.
Okay.
So I'll stop there, and I'm not going to let you ask if you have other historical questions because I don't have any other history.
Okay. That's it. That's
So,
fine.
but or maybe what you would want to know, but
Yeah.
what would you be thinking if I don't know if you've seen patients like this, but I'm curious what your
Yeah.
thoughts are.
Yeah. So I have a couple thoughts. In a kind of tricky situation. I think the things that I would be asking or talking to the patient in the EMG lab would be, trying to get, and sometimes it's hard, but trying to get a better understanding of a timeline of exactly when her symptoms started in that shoulder. as far as was it right away, kind of woke up with those symptoms that she's noticing, or was there a little bit of a delay? Did it progress over time? I don't know if we had a sense. And sometimes it's really hard for patients to tell you that because they're immobilized or pain medicines, but I don't know if she had mentioned anything like that.
Yeah, I don't think that it had progressed, but again, it was hard to tell from the history. I think, and I did kind of look back that surgery was done elsewhere, so I was trying to look in the record to see did she wake up with it, and from what I could tell and looking through the notes, there wasn't a lot of uh, notations in the history, even through the oncology notes, that she was complaining of shoulder pain. So
Okay.
my suspicion is it probably happened around the time, but she was dealing with all sorts of other issues that maybe that took a back seat.
Yes. Yeah. And it can be hard for patients to recall that, or I've had, run into that before. I think at that point, the other thing I think through, whenever I'm seeing a patient in the lab is trying to think about localization and where could this be in the nervous system. And that kind of helps guide me of what I'm thinking for the differential. And so kind of thinking through the possibilities, I think that um, I don't know if do you like top down or bottom up thinking through the peripheral nerve axis? I don't know if you have a favorite way to do it, but
Yeah, I mean, this is an interesting question. When we're teaching our residents and they're sort of learning the peripheral nervous system, I think it's important to be systematic and either go top down or bottom up. I don't really care, but what I often like is the next level of localization is prioritization, right? So,
yes.
kind of like, what do you really think? And then what are the next few possibilities?
Yeah.
You, but
Yeah.
but you're my guest, so you do it however you want.
I'll do it. I'm going to do it how I want. Now, I would think through, so I kind of take top down approach. And so, probably thinking if motor neuron versus, there's radiculopathy or nerve root, plexus, nerve, neuromuscular junction, and muscle. Just based off the story, I'd be thinking of, are there mononeuropathies? So, for example, lateral winging of the scapula, is this like a long thoracic neuropathy? I'm very suspicious about the shoulder shrug because that right cervical neck dissection, that area that they will often operate on, your spinal accessory nerve is at high risk. And so certainly I've seen some spinal accessory neuropathies after that type of surgery when they're just doing a dissection. But and so that would probably be the highest thing on my differential. Other things I think about, and this was kind of the question I was getting at earlier, is there plexopathy or something else more diffuse going on? And that could either be like a post-surgical inflammatory brachial plexopathy that happens. Often there's a delay, and then you have an onset of symptoms and progression over time, or she does have a history of cancer. Does that somehow now recurred and or metastasized or somehow involve the plexus? And I think those would be my top differentials.
Yeah.
Thinking through it.
Do you think that a non-neuromuscular problem could be there too? I mean, we see that all the time, patients with shoulder issues. I probably wouldn't
Yeah.
be presenting it if it was not a
I don't know if
neuromuscular
maybe
problem.
on an EMG talk here, but yeah, no, I mean, certainly, for example, like a frozen shoulder or a rotator cuff tear or something that's more musculoskeletal. That's typically what I'd say. That's not directly neurologic. That could certainly cause pain and weakness and symptoms in the arm too. So I think that's a good point. Trying to keep all those things, is it neurologic? Is it not in your differential?
Yeah. I guess if there truly was winging of the scapula, based on the information we have, would make that perhaps less likely. Non, but yeah, limited range of motion, pain in the shoulder. It's funny. I think this is going to age me, but as I've gone through these episodes, over the several episodes, I've talked about different nerve problems I've had, and I've had a frozen shoulder once
Oh,
also.
did you? Oh,
Not
wow.
not much fun, but it does limit your very significantly the range of motion. So,
Yes.
but the winging of the scapula, if that's true, is would be a little unusual.
Yeah, I agree. That pushes me to think that there probably is some underlying, neuromuscular problem here.
You mentioned spinal accessory neuropathy, and I don't know your experience or if you've seen patients with that, but do they, I mean, that goes, that supplies a muscle, but does that cause pain? Have you, in the patients you've seen?
It's a good question. I think that I've seen mostly weakness. Sometimes what I've also seen some patients have is because they're weak, they're kind of overcompensating with their shoulder and their arm, and they start to get some like rotator cuff tear or impingement or something that's musculoskeletal that gives them some pain on top of it. But but the neuropathy itself, I would think that that would be just more weakness.
Yeah. Yeah, and I've seen a number of patients, and the ones I've seen actually have quite severe pain. And I think your point's a good one, is that just secondary pain, but I think there probably are pain fibers in that nerve, and they have this really bad pain that you wouldn't necessarily think they would have,
Yeah.
but they do. And what about it? What about if again, because you raised this possibility, what about if can the shoulder shrug be normal in a spinal accessory neuropathy?
Well, good question. I guess it depends what it affects, as far as, spinal accessory. Is it affecting, your trap or your sternocleidomastoid? So maybe if it's sparing the trap and affecting more of the sternocleidomastoid muscle, perhaps, I suppose.
Yeah.
But I'm suspicious.
Yeah. And I think some people might even compensate for that. And the other thing is, if we're examining a patient just in the EMG lab and they're laying on the bed, and I think if people don't do a really careful exam, you're not going to see that shoulder dip, and it
Yeah,
might look like they have normal, that they have normal shoulder movement, and without really being carefully looking at them from behind and seeing that asymmetry.
yeah, that's a good point too.
Yeah. All right. No, great thoughts. So, okay. So, what would you do?
Yeah, yeah. So I would, after thinking about it and, talking to the patient, thinking through localization, then I'd start with some nerve conductions. I would start simple and expand from there personally. So I would do the right upper limb, like median and ulnar motor studies, median and ulnar antidromics as well. And then I might stop and do a needle, but I don't think you'd be wrong to also do some additional, nerve conductions, like doing like if you're concerned about. Well, I guess all we have right now is lateral winging, but I don't know. I'm still suspicious about the spinal accessory. We'll see, but you can always do a spinal accessory nerve conduction. But um,
Okay.
that would probably be my approach.
Why would you do the conductions in the arm, the median and
Yeah,
ulnars?
yeah, good question. So I'd be again. I still want to make sure that I'm not missing something more diffuse, like a more of a plexopathy.
Yeah.
I think that would be helpful to know that. You know, even though I'm still thinking kind of mononeuropathies is the highest on my list, I want to consider all those options.
Yeah, I agree. I mean, I think you could argue, and this gets to the point of, we have these protocols and these routine things that we do, but you could argue just go to the spinal accessory first,
Sure.
assess that first if that's your highest level of suspicion. But you're right. I mean, this patient had metastatic cancer, other things. Could this, you asked, the time course, and could this have been a Parsonage Turner syndrome or something like that? And maybe we would see some patchy abnormalities that clinically aren't apparent. So, all right. So let me show you a couple pictures here. So, what was done at Mayo, which isn't surprising compared to what from what you said, is some routine conductions were performed in the arm. So the median motor looks good. We won't need to belabor these, but and they did F waves, which were normal. The ulnar motor was normal. She's 80. So a little funny looking waveform, but it was within normal limits.
Yeah.
And her ulnar F waves look good. And then they did exactly what you said. They did ulnar antidromic and the median sensory antidromic, and these are all normal.
Okay, looking good.
So you would stick next.
Yeah, honestly, I probably would. And that might guide me on what additional, if I want additional nerve conduction studies.
So what
But
muscles would you stick?
yeah, so I would I would still test an arm. So doing the right upper limb, I probably would do, FDI, biceps, triceps, deltoid, and then I'd be looking at them. Um, if they have scapular winging, I'd be thinking about, doing shoulder girdle muscles as well. And so think about long thoracic, but I'd also be interested in probably rhomboid and trapezius as well. Thinking through the different muscles that could cause, scapular winging too. But I'd be, as I'm doing the needle, I don't know if you do this too, but I'm kind of, often we start with the patient lying down and it's a little bit dynamic. It's giving me a chance to get up close and also do more of an exam and take a closer look at everything. And then I have them turn on their side to do the shoulder girdle muscles. And I'm still, looking as I'm doing it.
Yeah. Yeah, I agree. I do the same thing, but like I said earlier, I often, if by history I have a suspicion of something like long thoracic or spinal accessory, I get the patient to sit upright. In our lab, we know, they're laying in bed.
Yes.
Nerve conductions, the techs have done the nerve conductions, they're laying down in bed. I get them up. Sometimes I'll have them swing their legs around, sit on the side of the bed, and then do the maneuvers to look for scapular winging, look for atrophy before I am doing that with the needle exam.
Yeah, sure.
Yeah. So, okay. So let me just show you what was done on the needle exam. I don't think I did this study. This is an older study I pulled from our archives. So we can both critique this. So but no, I think these are the muscles that were done. So for those listening, this is the table. I'm not going to show you EMG waveforms, but the trapezius, both the upper and the middle, demonstrated fibrillations, 1 to 2+ fibrillations, and no voluntary activation of motor units. And then the supraspinatus, serratus, anterior infraspinatus, and deltoid were all normal. So in this patient, other limb muscles were not performed.
Sure. Um, yeah, it's very interesting. So here's this probably the spinal accessory with this, trapezius being involved. Um, yeah, I don't know. Um, I think that's helpful. I'm kind of curious about some other muscles. I mean, I probably would have I've thought about sticking some other ones too. I don't know about you.
Which ones?
Yeah, I'd be interested. I probably think about sticking or testing SCM.
Okay.
And I might also look at a rhomboid as well and just see
Okay.
if any of those scapular muscles that are muscles that help stabilize the scapula are affected or not. Probably not. It's probably just, the trapezius is affected, but I'd be thinking about it.
So it's interesting. Do you always do the sternocleidomastoid when you suspect spinal accessory neuropathy?
Yeah, that's a good question. Um, I think I mostly do, but mostly because I'm curious when it's affected. Certainly I think it depends on where, uh, presumably this is happening at the time of surgery or, there's a transection or something. That's kind of high risk real estate. But I kind of get curious, and certainly you could have the sternocleidomastoid spared in that.
Yeah.
But I tend to test both if I'm thinking about it. I don't know.
Yeah,
What do you
it,
do?
no, that's interesting. I often don't, and I don't have a good answer as to why. I think you're right. I mean, I think if I see changes like this, then I'm pretty convinced it's a spinal accessory neuropathy. I think to your point, it may help localize, it may help tell which branches or how severe the spinal accessory neuropathy is. But I guess on the flip side, for me, does it really alter my interpretation or does it have an impact on the patient's prognosis if the SCM is affected or not? And I don't know
Yeah,
the answer to that. I think most people that I've seen when they have trouble, it's because the trap, which is such a big muscle, is really severely affected.
yeah. Yeah, I think that's good points. And then I think another thing too is just thinking, I'm always also very careful when I stick
Yeah,
sternocleidomastoid. I don't know if I'm always a little nervous when I'm going in and making sure I can really palpate where, the
yeah,
carotid artery is and just being very careful.
absolutely. I mean, and particularly if someone has an atrophic sternocleidomastoid, that could
Yes.
be so small that there's just a sliver of muscle. So I agree. I really am careful avoiding, being very superficial and being careful about the vasculature. So, all right. So now if you did this, would you do the nerve conduction studies? Or
Yeah, that's a good question. I mean, technically we've localized it with the needle, but I probably still do the nerve conduction studies. I think there's still personally value in seeing it, seeing if we can get a response. Although I'll probably have to compare it to the other side. So I know that is a few more shocks for the patient. But I probably would.
yeah. Yeah, I would too. I think it gives a good objective measure that may or may not, and we'll talk about this in a few minutes, but may or may not help with prognostication. So and to be honest, I think I don't know how you feel, but I think in most patients performing a spinal accessory nerve conduction study is actually pretty easy to do.
Yeah, I agree. I think that's not that hard of one to perform.
Yeah. So in this patient, it was performed. So this was the right side, the affected side. So the amplitude here is about zero point 0.9 millivolts. And the unaffected, the normal side, the amplitude was 6.6 millivolts.
Oh, wow. Okay. Well, that's a pretty
So
big difference.
yeah, but I'm curious now. So here, this is a situation where there's a response here. Would you think there's a response?
I, I think there's a response.
It sure
I
looks
don't,
like it.
I, I guess I don't know where that response is coming from, but but it looks like there's a response. Agree.
Yeah. So, if you think about the needle exam, which show one or two plus fibrillations and no activation, yet you have this CMAP that looks like there's a response. You're kind of getting at this. How do you justify that? That if
Yeah,
there's no motor unit, shouldn't there be no response?
yeah. That's kind of it's discordant. I agree. I think I think that's a good point because we really didn't get any activation. We're presumably recording over trap, so that makes me think that this response, maybe that's not trap, maybe that's a different muscle that's in that area that we're recording. Because when we're stimulating, we're trying to stimulate the spinal accessory solely that and also record that. But that area is kind of prime real estate. There's a lot of muscles in there that could get activated. And then I don't know if we'll talk more about this too, but also I think where you place your electrodes matter as far as your G1 and your G2 electrodes.
Yeah. Yeah, and I think, and this is hard to see, but if you look at how much current was given, which is shown right here, it was 58 milliamps of current. So when you're doing the spinal accessory, how much current is usually necessary.
It doesn't take much, you know. I mean, I typically, well, on a thin individual where it's a normal muscle of, 20, 30 milliamps, I don't know, it doesn't take a whole lot to stimulate. So that is kind of a higher
Yeah.
current.
Yeah, and just, for a teaching purpose, I just threw this picture of showing the spinal accessory setup the way we do it, as you know this. But I think that's an important teaching point for anyone who's learning to do these or is performing these, that, you can see in this picture that nerve is very superficial. And I agree with you 100% that in most people, even with larger necks, you shouldn't need more than 20 or 30 milliamps to fully depolarize that nerve. And the biggest pitfall I see is the stimulator's not over the nerve. People aren't sliding the stimulator sometimes rostrally or caudally to find that nerve. So when I see 60 milliamps, then I do wonder, are they overstimulating, bringing in, a suprascapular or something else, and that is just volume conductive response from something.
Yeah, yeah, I think that's a good point.
Let me ask you a what if question. So what if you got these nerve conduction studies? So same nerve conduction studies, and then and I showed you the needle exam of the trapezius, and the trapezius needle examination was normal. There were a ton of motor unit potentials, normal recruitment, no fibrillation potentials. Because I've
Yeah,
seen that happen in studies that like this.
yeah. Well, I'd be really suspicious about the setup for that nerve conduction, because if you're really having a normal needle exam, you should be getting some type of response.
Yeah. Or what's the other thing? What if the
Or
setup's perfectly fine and the conductions are perfectly fine
or
with the
or
needle?
your needle is not really in the trap. Maybe
Yes.
the trap. I guess that's true. That's a good point. I have seen where the trap has been so atrophic, you're actually in a different type of muscle, or you're not just in the right place.
Yeah. I think that's a really important point. And I've seen patients here in our lab that were performed, had a severe spinal accessory neuropathy. The EMG was interpreted as normal, and then they come back for a repeat study to see if there's any improvement. And when I've done the needle exam, that trapezius width is a millimeter. And if you pay attention, I remember a couple of these patients that when you get into that, there are these tiny little fibrillations. And if you go a little bit further, they disappear and you're in the supraspinatus.
Yeah,
And then the patient activates, they try to raise their arm, they can't shrug, but then they abduct a little bit and you get tons of normal motor units. So that thin trap you could pop right through that with a needle. You have to be really careful.
yeah, that's a good point. Yeah,
Yeah. And I suppose there are other ways to look at the trap as well.
yes. As far as um,
Imaging.
yeah, you could image like get an ultrasound or look at the muscle itself.
Exactly. So, and just to show, and this is not from this patient, but it just is showing a good example of a patient, different patient that had a spinal accessory neuropathy. And you can see well, I'll show this video. Um, you can see the trapezius normally right here thicken when the patient contracts. And then on the affected side over here, you see the hyperechoic muscle, and the muscle doesn't really move when the patient's trying to contract there. So
Yeah,
I think that's a really good supplementary tool to look at that muscle.
yeah. Actually, I think that's a really good point because it's easy to do. In the EMG lab, when you're there, and if you're not sure, you can just take that ultrasound and look, and that wouldn't take that much time.
Yeah, yeah. And I think it also helps you if things aren't adding up with the needle. And if you see that trapezius is really thin, then it helps understand that, boy, it may be hard to record anything from it. Yeah. So lastly, just what about prognosis? So this patient had no activation, had maybe a CMAP. Uh, would you say in your report and let's say that this is a few months after. I think it was longer, but could you would you mention anything about prognosis or not?
Yeah, that's a good question. Um, this is, well, first, and you said it was several months after. I think after nerve injury, if I'm seeing pretty this severe features of no CMAP and no activation, I'm getting concerned about, their prognosis and how much recovery they might have over time. Um, you know, I I don't know if I would necessarily personally add a whole lot of detail in the report on prognosis. I guess I'm more careful, I'm careful about that. But those are patients where I still think that it can take a while for nerve injury to improve. Sometimes we say months, maybe even up to 2 years after a nerve injury for symptom improvement. But if it's already been several months and they're not having any activation, I get a little concerned.
Yeah. Do you think that the CMAP, you mentioned that earlier, that the side to side difference in the CMAP helps with prognosis?
It's a good question. Um,
It does with the facial, right? We use that for facials.
yeah, yeah, yeah. I mean, I don't see why not, I suppose, with the trap, although I guess I'd have to look more into that one for the trap.
Well, I looked it up for you.
Thank you.
So I'm going to just show one slide because I learned from this as I was preparing this. Because I would have said by common sense is that yeah, if the ampli with facial we say if it's 10% or less of the normal side, that it's a poor prognosis for full recovery, right? And if it's higher, if the CMAP's higher than 10%, there's probably a better prognosis. So in my mind, I thought, well, is that true for this trapezius? And
Yeah,
this was an interesting study. I'm not going to go into a lot of detail, but people can look at the reference in Muscle and Nerve. But this was a Mayo study from a couple of previous fellows years ago and Dr. Harper, who looked at a number of patients that had a spinal accessory neuropathy at Mayo. They had 56 patients, and they basically looked to see is there any electrodiagnostic finding that would prognosticate that the patient would do well or not. And interestingly, kind of contrary to what I expected, they basically found that no, there were no features that really were helpful from a prognostic standpoint. Many of the patients had a pretty good outcome no matter what,
hmm,
and they defined that by how much they could raise their arm and things like that. And they didn't find any correlation with the degree of fibrillation potentials or the CMAP amplitude. If it was less than 25% of the contralateral, they didn't see any significant difference. The only thing they found that did prognosticate is if they repeated the study, um, and there was improvement, even if it was low, in the CMAP to over 50% on a repeat study, then that obviously suggested a better outcome.
yeah,
And they also found that the traumatic, they separate these out into inflammatory and traumatic, and they thought that found that the traumatic neuropathies had a poorer prognosis.
that was very interesting. So
Yeah.
maybe some hope.
Yeah, and it made me wonder, it doesn't quite make sense. You think if there were dense fibrillations, there weren't many motor unit potentials, there was a poor CMAP, that prognosis is going to be pretty poor. And
Yeah,
I just wonder if maybe it's that how do you define a poor outcome in that nerve when there's compensatory muscles that allow people to function, so maybe they're not feeling as weak as they would if they had weakness in the median or ulnar nerve.
yeah, that's really interesting. I also wonder, and if there's a difference too between if it's a partial spinal accessory or if there's a full spinal accessory, like if the sternocleidomastoid is affected too. I don't know.
Yeah. And I don't remember in the paper if they separated that out. I think I'm not sure that they looked at that muscle.
Okay.
So so interesting, right? So this
Yeah.
patient so So, I think this kind of tells us that, there is an important role for EMG in these patients that have vague shoulder symptoms in terms of diagnosis and maybe not, maybe prognosis, but maybe not.
Yeah, no, I think that's really a good point. That's helpful and to look at that and think through which muscles could be affected in that area.
Yeah. And I think the other thing, I don't know, again, I asked your experience with these, but in the ones you've seen, I think you said they've been mostly traumatic. Is that the right?
Yeah, I have. I've seen. I think it's helpful, for a couple reasons. If you're seeing, I've seen a couple different things. So if it's traumatic, and I've also seen things where it's like a double hip. I don't know if you've, have had some of those patients where, when they're coming in with a wing scapula or maybe two, mononeuropathies that started at the time, one is traumatic and maybe one's inflammatory, like that happens, post-surgical. So I've seen that too. But I think that's helpful because, when you're doing the exam and seeing a wing scapula, that's where the EMG is nice because we can nail that down. If it's solely a spinal accessory, then I think, okay, that probably is traumatic at the time of the surgery. Versus if there's other, mononeuropathies there, I'm a little more suspicious that maybe there was like another hit or like an inflammatory situation going on too.
Yeah, and I think to your point earlier that that is a good reason to not just needle one or two muscles, but to expand the needle exam. I mean, this patient didn't have any evidence of other nerves involved, and I think anytime the ones I've seen that have had neck surgery or lymph node biopsy, it's pretty obvious that that nerve is cut or traumatized.
Yeah.
But yes, if there wasn't a history of that, then absolutely, I think not just assuming it's one nerve and expanding the needle exam can be really helpful. So, well, good. Well, thanks for letting me pick your brain. I'm glad we think alike. Uh,
Yes. Yes.
but there's a few differences, and I think that's good. Even within our lab, we have a few differences in how we might approach a patient. And uh, as I always say, there's no one right way of doing things.
Yeah, no, thank you so much for having me. I always learn, so much through these cases, even today. So I
Yeah,
appreciate it.
I think that's again, we work together all the time. And even if it seems like it's a run-of-the-mill simple case, we can always find something to learn or think about from the case. And even, I always think it's important to step back when we have a busy day, we're backed up on patients, to take a deep breath and think about what we're actually doing, what this data tells us. And that's how we learn and that's how we keep our minds fresh.
Yeah, for sure.
So, well, terrific. Well, thanks for ending your day with this. This has been a highlight of my day, and I'll see you around probably in like 10 minutes.
Yeah, sounds good. See you around the corner.
Yeah.
Take care.
All
Thanks
right.
again.
Bye bye. I hope you enjoyed another episode of Lessons from the Lab. As always, there were some really useful, instructive points. I certainly learned from this case and from reading the article that I presented. Think it's always important to keep neuromuscular conditions in the differential diagnosis, particularly in patients who present with orthopedic type of issues. It's obviously important to perform a really careful neuromuscular examination, particularly when symptoms are periscapular and you're looking for subtle abnormalities behind the shoulder. And then, of course, performing the appropriate nerve conduction studies and needle examination is important. I did mention in the discussion some technical problems that can sometimes be difficult to interpret, such as the performance of the spinal accessory nerve conduction study, in which overstimulation may lead to a false positive response. And that it wasn't really shown in this case, but as I mentioned, sometimes the needle examination may may miss abnormalities in a very atrophic and thin trapezius muscle. So that's something really important to be aware of. So I hope it was beneficial for you. I hope you learned something, and I look forward to the next lessons from the lab. Goodbye.